pain is something that you all know. Pain is something that we all understand. It's a common experience. And if we asked somebody in childbirth, they'd quite simply tell us it was the most painful thing that it's possible to experience. Ask somebody with chronic pain, and the meaning of that pain is entirely different, isn't it? And so this has led the sort of reductionist side of pain, the understanding of pain, just to simply saying exactly that. It's what the patient tells us. I think when you sort of rarefy that down into what it means for a patient, it's been described as a somatopsychic phenomenon. This is a pure somatopsychic phenomenon. It's all down to what you perceive the pain to be, isn't it? We all know that. It's usually, talked about in terms of tissue injury or potential tissue injury. And it's an unpleasant experience. That's kind of an obvious thing to say, isn't it? But pain in and of itself is a negative experience. It's completely down to the context of pain. Robert Twycross always talked about it in terms of your mood, your morale, and the meaning of the pain for that patient. That opens up a little gateway. That of itself I don't think explains much, but it opens up a gateway to tell us those patients in whom we're likely to get good pain control. It will come as absolutely no surprise, and particularly for those of us in palliative care, because the hospice movement actually took this and encapsulated all of these things to try and make people's pain better. And you know as well as I do, when you get a patient who is suffering on their own, feeling isolated, abandoned, angry, sad, that feel that their oncologist, for example, has abandoned them, the minute you embrace them and bring them into your own primary care world or into the world of the hospice, suddenly they get better. Suddenly their pain scores drop down. The psychological component of pain relief is so massive. And this is what Cicely Saunders saw when she taught us about the concept of total pain. And we'll just talk about that in a minute. When we sort of love our patients and we understand them, and our continuity is good, and our communication with them is good, we get them sleeping, we get them understanding their pain, we make them feel less isolated, we reduce their anxiety. Anxiety, just as it will come through all of palliative care, anxiety and anger, misunderstanding and lack of communication are the things that drive pain, sickness and most other symptoms. That's sensible, isn't it? That's kind of what we all know in primary and secondary care, isn't it? Cicely Saunders taught us that unless I understand my 30-year-old patient from the point of view of their physiology, from the point of view of what it means to him, I'm thinking about a specific patient, to not be able to be a father to his son anymore, and the husband to his wife, and the fact that this was a family that had a faith that lost their faith due to the spiritual agony that dying at 30 gives to you. Unless we understand our patients in those terms, you won't get good pain control, though you hit their mu receptor as hard as you like. It will not work. You know, this is where primary care is so incredible. And our colleagues, I'm going to say because ambulance service and all those people, those frontline people that go in for the first time, an understanding of pain, as Cicely Saunders taught us. You all know Cicely Saunders? Founded the hospice movement, became a social worker, a nurse and a doctor, so nobody could say that she didn't know what she was talking about. She was a phenomenal lady. She told us to think about pain as total pain. It works for any symptom set as well. So think about it in those terms, and you genuinely won't go far wrong. Here is the one relevant piece of neurophysiology for you. You remember that inside those muscles, inside the skin, there are nociceptors, and these are the things that are stimulated to give us pain. And the one thing I want to teach you, in case you don't know it, is if you look on the chart there, you can see that each of those fibre types falls into that posterior horn cell in 6 lamina, right? Why is that relevant? Why do I need to stay awake for the next minute? Because of this. There are billions of interneuronal connections. You've always been taught, or I've always been taught, that up they go, up the spinothalamic tract. They don't. They decussate, they go down spinal segments, they go up spinal segments, they go up and decussate, they go across. So each tiny pain nociceptive impulse has billions and billions of interneuronal connections. It's just a bit more complicated than we thought, really. All the signalling and transduction mechanisms of the spinal cord are hugely complicated. In fact, it's a bit like this. Then we're going to, I'm probably flogging this train analogy a bit here, but if we superimpose, other systems onto it as well, pain is completely caught up. It isn't a single phenomena. It's entirely dependent on your psychology, on your mood, on your physiology, on the context of that pain. When you have a pain response, you'll remember that if I have a painful stimulus on my hand, for example, there will be an immediate afferent interspinal cord and out again. So I have a pain withdrawal response. And then those nociceptors will start firing, telling me that I've got pain. We call that primary hyperalgesia. But then, as you'll remember, all of this ingress of chemical soup of bradykinins, prostaglandins, histamine forms an area outside. And you know when you've had pain yourself, and that whole area then becomes painful, doesn't it? It sort of isolates itself almost. And that's an adaptive mechanism. When we've got pain. Inside the spinal cord, when lots and lots of pain stimuli are coming through, lots of different trains are coming into that station, the synaptic world, if you like, the synaptic milieu will start, like this baggage carousel, start getting lots and lots of bits of baggage on it. It will start firing off. There'll be an increase in those synaptic transmitters. And this is we call synaptic plasticity or synaptic wind-up, central sensitization, central wind-up, lots of different names for it. But basically means that single nociceptive response that is just a small pain, when it becomes chronic, the spinal cord will undergo a transformation and amplify that pain response. Central sensitization. This is familiar to all of you, hopefully. Do you like the carousel? That kind of works, doesn't it? Suddenly you've got all these bags coming round, an otherwise empty carousel. So you've got many more neurotransmitters being fired off. This is a concept of central sensitization or synaptic plasticity. And in chronic pain, it becomes incredibly important because it's the thing that we try to modulate. Morphine's pretty good for most pain types. There will always be a number needed to treat. And trying it out is the right thing to do for our patients with severe pain. I'm talking here, by the way, not in chronic, but I'm talking about patients who are in the palliative phase. You know as well as I do that morphine has a number of effects. We talked about presynaptic and synaptic plasticity. When you use morphine in the long term, it has massive effects on your immune system, on your adrenergic and your noradrenergic system, on your androgens. So the effect of morphine in your body in chronic use is actually very, very dangerous and very, very problematic. Cardiovascular problems with the long term of morphine, and this is why in pain clinics morphine trying to steer clear of using the opioids and the opiates. So this is really talking about those patients who have pain from malignant, non-malignant disease, who are coming towards the end, in whom the problems are going to be less. So the individual response to morphine will always vary. You can give somebody 10 milligrams of morphine and they'll thank you forever. You can give somebody 10 milligrams of morphine and they will be flat on their back with a respiratory rate of 8 and you'll be terrified. You're going to look at that and think 5 to 10 milligrams of oral morphine is quite a low dose. It is, but think about little old ladies, think about little old men on their own. You're going to start giving them opiates. Their tendency to fall might increase, for example. So start low. You can always go up. Once a patient loses faith in the drug, it made me feel dreadful, doctor. You've had it. That's the end of you ever using one of those drugs again. And a little bit about fentanyl there. Just to remember that this is a synthetic opioid, much less constipating than morphine and diamorphine. But just be cautious with it because the doses are much higher than I think we realise, really. Yeah, and that's the other thing, is when you discontinue a patch, you've got 17 hours of wash in and wash out with fentanyl. So you really are fighting. And the point this reminds me to make is that if you've got a patient who's on a fentanyl patch and their pain was stable, suddenly isn't stable, is no longer stable, keep the patch on, change it every 3 days as you would normally, and add in an opiate on top. Don't take the patch off and try and convert. You can't. There is a thing that we use in hospice called the rule of fives. When we divide the fentanyl dose by 5, that gives you the 4-hourly morphine dose. I don't think it works. I've got to tell you, add on top of your fentanyl. Is that what you all do that anyway, I'm sure? You are absolutely the drug for your patients. You truly, I can't overemphasize that, because I look at this list and I think, oh great, yeah, well, all kind of clever things on there, analgesic, analgesic, TENS, all those things that we all know how to use. But tailoring that to your individual patient, James, I think you were always a great example of this at the hospice. When patients always say, "Where's James?" Patients want to see that doctor. They want to see that you make a difference to your patients. If we go mad, we can think about all the clever things that we can do. We can give surgery, we can give anaesthetic agents. Propofol is sometimes what we have to use if we're not, winning with our patients, and we've had to use that on several occasions. Cordotomies and nerve blocks are things when we really get stuck. But in all honesty, 90% plus of our patients will be able to manage in the way that we've mentioned today, with the added factor of remembering that patient's psychological, social and spiritual world. It relies on you setting realistic goals for your patient. You won't get rid of all your pain and all your patients. It's that straightforward. You're still going to have some pain, but it will be manageable pain.
I think the take-home message from this evening is to have more confidence really in using palliative care drugs. I'd always felt quite hesitant and nervous about doing that, but I think this has given me a bit more confidence to use some of them and how to use them really.
I found tonight a really useful and informative session with lots of learning points about pain management, in particular probably bearing in mind using paracetamol at any point in the pain ladder, and also the GP can have a really important role in managing patients' pain relief, and patients can see their input as really beneficial to them in helping, not just by providing them with drugs, but by helping them manage again with those emotional aspects of pain as well.
So I think the take-home points for tonight are, the first is just to remember that pain isn't just a physiological phenomenon. It's also involved in the social, psychological and spiritual world of the patient. And that really feeds into the fact that the health professional themselves forms part of pain management. We know that patients who feel isolated, abandoned, anxious or worried or frightened, we won't achieve as good pain relief in. And I think the other thing to remember is about morphine. Morphine is actually a reasonably safe drug to use. We have an increasing use of fentanyl in patients in stable pain and unstable pain. And I think tonight was a real reminder that the WHO and NICE suggest that we use morphine as first line and gold standard in opiate responsive pain or opioid responsive pain. I'd remind everyone that fentanyl patches, 25 micrograms per hour of fentanyl is the equivalent of 90 milligrams a day of morphine, and I'm not sure that everybody appreciated that these are actually very high doses. So fentanyl is a drug that's, whilst it's good for some patients with stable pain, we don't tend to use in palliative care, particularly in its patch form.